Good evening, everyone. A warm welcome to the APOS Oculoplasty lecture series number 8 by Dr. Subramaniam sir. Today's topic is on interpretation of CT scan. With this introduction, I would like to hand over the session to Dr. Subramaniam sir. Sir, please continue the session, sir.
Thank you so much. Good evening and warm welcome to all of you. Today I'll be speaking about interpretation of CT orbit. That's main focus. Okay. Orbit is considered to be a Pandora's box, especially when I was a postgraduate student, because the only investigations that were present at that time are just X-rays. So, to be honest with you, we can say that it's not a useful investigation at all. So that when the case of proptosis is taken up for surgery, surprises in the OT are very common. So, what they used to do is something like a team effort. It's the neurologist and the ophthalmologist together. They used to do the surgery under general anesthesia, so that if there is any unexpected extension into the brain or the surrounding structures, the neurologist will come to help. For this reason, it was more a team effort rather than an individual surgeon's, orbital surgeon's effort in the good olden days. So, what does the CT scan give us information? It tells us the anatomical location, whether that lesion is confined to the orbit or is extending to surrounding structures, into the sinuses or into the brain. Is it in the intracorneal space or peripheral surgical space? So that you can plan your approach, and also you can prepare for the eventualities. It tells you the nature of the lesion, whether it is a solid or a cyst, whether it is well defined or whether it has infiltrating borders, whether it is highly vascular or less vascular, and whether it is a benign lesion, a malignant lesion primarily, or a metastatic lesion. So this amount of information is given to us by the CT scan. It also tells us histopathological diagnosis in most of the cases, like thyroid-associated orbitopathy. You can definitely identify looking at the CT scan in the clinical picture. Similarly, it tells you whether it is a glioma of the optic nerve or optic nerve sheath meningioma when there is an axial proptosis with defective vision. Similarly, a sphenoid ridge meningioma can be easily identified by looking at the CT scan. It tells you whether it is a case of a cavernous hemangioma, which more commonly is in the intracorneal space, or is it a schwannoma? And the way they behave in contrast, you can differentiate a hemangioma from schwannoma. The contrast enhancement starts at a point in cavernous hemangioma and slowly spreads, whereas in schwannoma, it's diffused to start and spreads more rapidly. Similarly, we can diagnose myocystis looking at the CT scan. Same is the case with lymphoma, lymphangioma, idiopathic arterial inflammation, and so many other things. So, the CT scan gives us so much of information, we can call it as more an anatomical diagnosis depending on where it is located, and also some amount of histopathological diagnosis, so that you have enough information to plan an effective strategy. What are the principles of CT scan? CT scan is computerized or computed tomography. What is tomography? Tomography is a technique where the source of the X-ray rotates and the plate which receives the X-rays also rotates in the opposite direction, keeping the point of interest at focus, so that the unwanted things are blurred and you get a good quality of the area of our interest. In computerized tomography, the patient is driven into the tomograph machine. Here you have an X-ray beam that comes out as it rotates, and here you have the receivers or X-ray detectors which receive the X-ray beams, and it also rotates in the opposite direction as the X-ray beam is rotating. Both rotate in clockwise in opposite directions. From the X-ray detector, it is connected to the computer, which analyzes the inputs that are received by the X-ray detector and converts it into an image. So different tissues attenuate the X-rays as they pass through at different levels. So these attenuation values, otherwise known as Hounsfield units, tell us what is the structure that we are looking at. If the value is minus 1000, that's the lowest. Metal and thick cortical bones have plus 1000, and all the other things are in between the two. A that is in the sinuses, you can see, is minus 1000. Fat is minus 100 to 150. So, as you are aware, orbit is full of fat. So, this gives an excellent contrast over which the other structures of the orbit are seen very well and very clearly. And if you look at the amount of blackness, the blackness of fat is not as dark or as black as that of the air, as you can see in this picture, in the CT scan picture. Water is 0, CSF 0 to plus 5, optic nerve plus 5 to plus 10, vitreous plus 5 to 15, soft tissues plus 30 to plus 40, blood, that's hemorrhage, plus 70 to plus 80, calcification around plus 100 to a little more, particle bone plus 300 to 1000, and metal more than 1000 units. So when there is a lesion, and if the Hounsfield units are also informed by the radiologist, we'll have a pretty good idea of what are the contents in that. What are the indications for CT scan? Every case of proptosis. Unexplained ptosis, because ptosis could be due to a neurological ptosis, could be even due to intracranial tumors. For review of thyroid orbitopathy and myocystic unexplained vision loss, orbital trauma, orbital extension of lip and surface malignancies. If you want to rule it out, you have to get a CT scan, because the plan depends on whether there is an orbital extension or not. So that things come in two windows, soft tissue windows and bone windows. In soft tissue windows, the bone is seen as a very wide structure without any details. Whereas the soft tissue details are seen very, very clearly, as you can see the eyeball, the nerve, the muscles, the sinus, the infection in the sinus, the muscles, optic nerve, lens, everything, and a swelling of the eyelids. And also you can see a bone with a discontinuation of the lateral wall of the orbit. These are all very clearly seen. In bone window, you see the details of the bone more clearly, much more clearly, and the soft tissue lesions are not seen clearly. They are not seen clearly, they are masked. The bone windows are, the bone tissues are seen clearly. So these are different pictures of bone windows. These are the different tissues of pictures of the bone windows. So you can see that these are the bone windows above, where you are seeing the details of the bone, not the details of soft tissues. Whereas the same at soft tissue windows, you are seeing the bone as a painted white, nothing in it. And you can see that this sinus is involved, the nasal cavity is involved here. All these things you are able to see. Sinus involved here, the nasal cavity being involved here, which are not clearly depicted in the bone window. Now let's look at the previous investigations of X-rays. What information does the X-ray give us? Looking at this X-ray that you see here of orbital view and lateral view, what I can say, to be honest with you, is that this is most probably an X-ray of a woman. How can I say that? Because I can see this is probably the nose stud and a ear stud. Ear stud males are also used nowadays, but I think males do not use the nose stud. That's why I think it's case of a female X-ray. And also, if you look at the bones, it's a single row, so an adult female X-ray. Nothing more I can draw information from this. Nothing about the orbit or the tissues or anything. Whereas if a CT scan here, what you are able to see? You are able to see that here is a mass which is solid, uniform, hyperdense when compared to the brain or the brain, uniform density with very clear-cut margins. And you can see that this bone is bowing, that is called excavation. That means it is a long-standing one. The eyeball is pushed out since it is in the medial space. So it is causing an eccentric proptosis, very big mass extending from the floor to the roof. Even the floor is showing some amount of excavation, very clear-cut margins. So most probably it is a long-standing lesion, and most probably it is a benign solid lesion. And if you look in the other CT scan, what does it show? It shows a hyperdense mass again involving the entire peripheral and intracorneal space, with extending behind through the superior orbital fissure into the brain. And there's a minimal erosion in the lateral wall and a little excavation. Most probably it's a fungal granuloma. The eyeball contour is maintained. If the eyeball contour is maintained, it is usually either a lymphoma, adenoid cystic carcinoma, or a fungal granuloma. One of the three it should be. what other information it will be showing? Look at this. Here is a mass, very clear-cut borders, intracornal space, and it is a optic nerve glioma with cystic degeneration. You can see two cysts in the with an axial process. So it's a very, very long-standing lesion. And what does this show? This CT scan, the coronal section shows a very big mass. So with the nerve being compressed and entire orbital space is occupied by it. So it's a solid mass, uniform mass with clear-cut borders, again a benign lesion. Here, if you look at this, you are seeing a cyst, almost the size are a little bigger than the eyeball, with a clear-cut cystic border and a uniform fluid. The fluid is 21 HO, that is means it is much thicker than the vitreous, looking something like a second eye. It is a hydatid cyst. And if you look at the medial wall shows little excavation. So it is probably long-standing. Here you can see that there is a mass with borders which are not very clear-cut, and it has three components: an orbital component, an intracranial component, and it's extending into the temporal fossa. This is the hyperostosis of the sphenoid bone. This is a sphenoid-rich meningioma. So the diagnosis itself is written on the CT scan. It's very easy to make the diagnosis. So for the understanding of the CT scan, you must know, you should be able to identify the structures that are visible at different levels. So this is an inferior cut where you can see the anterior lacrimal crest. This is the lacrimal sac. This is the lacrimal sac on both the sides, anterior lacrimal crest, posterior lacrimal crest. This is the lacrimal sac. This is the oropharynx. Right. Here, what are you seeing? This is the lens, the vitreous cavity. Then you have the optic nerve, medial rectus, lateral rectus, and then this is the medial wall. This is the ethmoidal sinuses, anterior and posterior ethmoidal sinuses, sphenoid sinus. This is the optic canal, and this is the superior orbital fissure. You remember that if you want to comment that this is the optic nerve, you should be able to see another fissure, that is the superior orbital fissure. If you see only one, it is not optic nerve. We'll come to that a little later. In the superior cuts, what we are seeing here is this is the reflected tendon of the superior oblique. This is the lacrimal gland. This is the superior ophthalmic vein. This is the temporalis muscle, prestagory. So this is the superior ophthalmic vein, which is a little larger compared to this. I would like to talk a little about the common mistakes that are usually done by inexperienced and especially by residents. If you look at this axial scan of the CT, you are seeing the optic nerve here and optic nerve here. This part it is missing. And if it is following trauma and the patient loses vision, most of them say that it is the avulsion of the optic nerve. But it's wrong. If you look at the optic nerve has a sinuous course, it is not straight rod, it has a sinuous course, so that when the axial cut is taken, a part of it which is a little lower in the sinuous curve misses. So you may not be able to see the entire cord like optic nerve like this. You may be able to see this in the next cut. So this is the one mistake that many people commit. Second thing is, here you can see the optic nerve. Temporal to that, you see a cystic cavity. Here is the wall of the cyst, and this is the content. These are the contents of the cyst. So they feel that it is a cystic lesion of the orbit. But to be honest with you, what you are seeing is this is the optic nerve, and this is the posterior most part of the eyeball itself, right? Because the optic nerve is not the posterior most part. The posterior most part is the fovea centralis, and optic nerve is nasal to that. So whenever you see in the CT scan, the last one or two, you will be seeing the optic nerve and next to the posterior most part of the eyeball, which looks like a cyst. Of course, here this is a case of a patient with optic nerve glioma, that in the right eye, left eye is normal. When you look at this, many people say that this is enlarged optic nerve canal. Optic canal is enlarged on the right side. That's many people say, and say that it is an intracranial extension of the mass through the enlarged optic canal. But as I said earlier, this is the superior orbital fissure, and this is the superior orbital fissure that is enlarged. If you want to comment that is optic nerve, you should be able to see optic canal, and medial to that, so lateral to that, you should be able to see the superior orbital fissure. In other words, you should be able to see two canals, two fissures, right? One for the optic nerve, the other for the superior orbital fissure. So this is enlarged superior orbital fissure. So how to read? Whenever we see the CT scan, our eyes will go on to the soft tissue lesion. But we may be missing a few of important findings if we just jump into that. There is a way to read the CT scan so that you know what to read. And this could be an important one in the exams. They may keep one film and ask you to identify that. So you have to know the anatomical location or level of the lesion, level of the film, then look into the bony orbit, eyeball, extraocular muscles, optic nerve, and then to soft tissue lesions. In the soft tissue lesions, look at the borders, consistency, Hounsfield units, and contrast enhancement. These four you have to look at in the soft tissues. Normally, the X-rays, the CT scans are sequence for axial cuts from below upwards and for coronal cuts from anterior to posterior cuts. So when an axial cut is given to you film, you must know whether it is inferior cut, whether it is mid-level or superior cut. So how do you diagnose it? Remember that the medial walls are parallel to each other in the mid-level, and you will be seeing the medial rectus and the lateral rectus. And here, of course, you are seeing the optic nerve and superior orbital fissure also. But the most important thing is look at the medial walls. If they are parallel, it's the mid-cut. If they are not parallel, it could be either an inferior cut or a superior cut. Then look in front and behind. If you look in front, and if there is a prominence of the nasal part, and behind you see the oropharynx filled with air, this is an inferior cut. On the other hand, if the root of the nose in front is flat, and behind you see the brain tissue, it is the upper cut or superior level cut. And from anterior to posterior, you are going for the coronal cuts. Anteriorly, it's very spacious, and as you go posteriorly, it becomes narrow and narrower. As you see here, even in this, anteriorly it is spacious. As you go posteriorly, it becomes narrow and narrow in the coronal sections. Now, let's look at the bone. When the tumor is in relation to the bone wall, and if it is long-standing and the pressure is raised, what happens? There will be a bony excavation. Here you can see that there is a cyst. And if you look at the bone here on the medial side, it is excavated. You see, you look at the difference between this part and this straight one. This is a dermoid cyst, the medial part. Okay. If you look at this, I'm sorry. If you look at this, it is a big clear-cut lesion, whereas the lateral border is here, lateral wall is excavated. So is the bit of the medial wall. If you look at this inferior part and the superior part are excavated, and the total volume of this or weight in the coronal section is more than that of the other side. Here again you can say typical excavation of a cyst which is very huge, very big in size. And what has happened to the medial wall? So the medial wall has given way, it's not broken, it's excavated at a smooth curvature is there. And where is the level? This level is, these are not parallel. And here you see the reflected tendon of the superior oblique. So it is a upper level cut. So in thyroid orbitopathy, bilateral, if the medial rectus is very much thickened, what happens? Similar excavation of the medial walls occur on both sides. That is called the Coca-Cola sign. Here, if you look at this is not excavation. In excavation, the integrity is maintained and it is giving the contour changes occurring. Whereas here, the bone is eroded and the lesion from the maxillary sinus is extending into the orbit and outside. And here, these margins are a little irregular. It's a fungal granuloma from the maxillary sinus with orbital extension and way to the. Here again, you can see that the bone is eroded, the medial wall is eroded, and you can see the bony changes. Similarly, here also you can see that there's a severe proptosis. The posterior border of the eyeball is flattened, and this bone shows hyperostosis due to infiltration. And you can see that the bone is irregular. This is called erosion of the bone, and this is typical of a fungal granuloma. Here you can see a mass with involvement of the sinus, the orbit, and the brain, intracranial extension of the brain, with the roof being eroded and the bones being eroded. It is a sino-orbital intracranial mucormycosis. So here also again you can see another mass with bony erosion of sinuses extending into the frontal sinus, maxillary sinus, ethmoids, and also into the orbits and outside. And here you see a huge cyst without any bone. This is a tumble dermoid. What are the other bony changes that are important? Hypertrophy or hyperosteosis. Hyperosteosis typical of sphenoid meningioma. Sphenoid meningiomas could be involving the medial wall or the lateral wall and have intracranial components and also may have calcification. Here you can see a mass with the intracranial component and then orbital component and into the temporal fossa. Because of this temporal fossa extension, you will find fullness of the temporal fossa when you see the patient normally. And this bone, you compare it with the normal bone on the side, is hyperostotic. So this is the sphenoid meningioma lateral wall. This is sphenoid meningioma medial wall with contrast enhancement and calcification. Look at this lateral wall, the bone with this bone, and you can see the hyperostosis. Another case of sphenoid meningioma with severe hyperostosis, intracranial component, orbital component, and temporal component. This is a lesion of the bone. So tumors arising from the bone. This is an osteoma, and this is a soft tissue window showing the big osteoma from the ethmoid, and the bone window shows bosulated appearance and some more details of the bone with the bosulated appearance, and it's an ethmoid osteoma which we removed with a modified Lynch incision. Other important bony space occupying lesions are fibrous dysplasias. Fibrous dysplasias involve the flat bones of the face. So orbital involvement is quite common. So in fibrous dysplasia, you see a ground grass appearance with the bone that is being thickened with cystic spaces and a bit of calcification. The other important tumor is ossifying fibroma. In ossifying fibroma, you see a calcified scleral rim that is very clear cut. This type of rim you are not seeing in fibrous dysplasia, and it can have cystic spaces and calcification inside. Not move. Not move. Can I go back? No. Right. Okay. Now, if you look at this patient, here you see the periosteum. This thick line that you are seeing is the periosteum. And subperiosteal space is a potential space which may be filled either with pus, that is subperiosteal abscess, or hemorrhage after trauma, subperiosteal hemorrhage, blood. So subperiosteal abscess usually occurs following infection of the sinuses, either a frontal sinus or an ethmoidal sinus. Here you can see that there is an infection in the anterior ethmoidal sinus, and the wall is breached, and the pus is entering, and it has accumulated here, and there is subperiosteal space. And clinically here, the patient, you can see that has pain. There is fullness here. In the superior space, there is fullness. The eyeball is depressed. It's pushed downwards, and there's a lot of congestion. And it is a case of a subperiosteal abscess. Here is a big angiofibroma of the maxillary sinus, occupying the entire maxillary sinus, and the orbit space has been contracted, leading to severe proptosis, fullness in front of the cheek, and you can see the mass extending into the nose. And here you can see the lymphoma of the cornea due to exposure keratopathy. Fracture orbits. CT scan is very, very, very important to know in the management of fracture orbits. So here you can see a patient with a bit of anastomosis, and elevation is being restricted. So in this gentleman, the right eye is fractured, there is a minimum subconjunctival hemorrhage, elevation is restricted. And what does the CT scan show? The CT scan shows a huge fracture of the floor, and some of the bony fragments being displaced into the maxillary sinus, and probably this is the inferior rectus, and elevation is restricted because of the change in the position of the inferior rectus. If you look at this young girl who came with history of trauma, motility restriction, you can see subcongenital hemorrhage, motility restriction. We did FTT. FTT is positive, so we made a diagnosis of fracture floor of the orbit with entrapment of the inferior rectus. But what does the CT scan show? The CT scan shows that the floor is intact, perfect, normal, but there is a fractured roof with the bone that has turned inwards and that is pressing on the eyeball and preventing the movements mechanically. That is why FPT was positive. So we did a surgery, removed this spicule of the bone, and the patient has become normal. Fractured orbits, here you can see that this fracture is not as big as the previous one. But here what you are seeing, the inferior rectus is entrapped in the fracture. So this case needs surgery, and we have to release the inferior rectus from the entrapment and close the fracture with either polyethylene sheets or your metal sheet, these titanium sheets or something like that. Sometimes there could be a small fracture without entrapment, and a bit of fat and blood may collapse into that. This is called the teardrop sign. Then, after these bones, look at the eyeball. How is the eyeball? Where is the lesion? And what is the relationship between the lesion and the eyeball, and what is happening to the eyeball? Here you can see that there is a proptosis, a significant proptosis, and the mass is molding to the globe. The normal contour of the globe is not changed at all. This is called molding. Our mass is cutting around the eyeball without changing. This happens in, as I said earlier, lymphoma, fungal granuloma, and in case of lacrimal gland masses, adenoid cystic carcinoma of the lacrimal gland. Whereas this happens because most of them, these are soft tumors. If the tumor is solid, firm, or if the cyst is firm and it's solid, what it happens? It compresses the eyeball. This is the cyst and this is the eyeball. You can see how the eyeball has been disfigured, and this leads to astigmatism, and you can see that you are dealing with a cyst that is quite firm in consistency. Here you can see an intracorneal mass, a solid mass, which is flattened the posterior part of the eyeballs. It has been almost straightened, lost its curvature, and this leads to hyperopic shift in the refraction, and that's flattening of the posterior part has happened. That means we are dealing with a mass that is firm in consistency. If the proptosis is very severe, sometimes what can happen? The optic nerve, which has a sinuous curvature, is to accommodate the stretching of the eyeball as occurs in proptosis. But if proptosis is too much, what happens? It tends the posterior surface. You see compare the curvature of the posterior segment here and here. This is more acute. It's as if it has been pulling down. The optic nerve is pulling the eyeball back, or it's not giving way because it has stretched to its maximum. This is called the tenting of the eyeball, and this also can lead to defective vision. Again, look at this eyeball. Here is a mass which is cutting around the globe and is probably extending a little into the intracranial space. These are fungal granuloma. Here is a intracorneal mass which has flattened the posterior part of the eyeball, straightened it, and it's lost its normal curvature as you see here. And this is a solid mass with which we are dealing. Look at the eyeball. What else is there in the eyeball? Here is a patient with a leukocoria. And what does the CT show? The CT shows an intraocular mass with calcification, which is typical of retinoblastoma. Here you can see a patient with proptosis and a little bigger cornea, that is, and some white reflex that is there. Pupil is dilated, and you can see the amorphic cat's eye reflex. So what does the CT show? The CT shows proptosis with the posterior part being eroded, sclera, and the tumor has extended posteriorly into the orbit, and you can see that in the eye there is a lot of calcification in the tumor. So it's a retinoblastoma showing orbital extension with proptosis, and the other eye, which was enucleated previously, shows a recurrence with calcification, a bilateral retinoblastoma, familial in origin. Here is a patient with an intraocular mass that could be seen, which is brownish, and the slit lamp exam reveals blood vessels over it. And what does the CT show? The CT shows a mass which is hyperdense when compared to the vitreous without any calcification. You can see the mass. So this is typically a case of melanoma. So as you are aware, retinoblastoma and melanoma are the most common intraocular tumors in pediatric age group and in adults respectively. Retinoblastoma is characterized by the presence of calcification, whereas calcification is absent in melanoma. Then we'll go to the enlarged extraocular muscles. The two most important causes are thyroid-associated orbitopathy and myositis component of idiopathic orbital inflammation. They will ask, how do you differentiate on CT scan? This is the best slide to show the differences. Number one, in thyroid orbitopathy, the muscle is enlarged and the tendon is squared. Number two, usually multiple muscles are involved. It may be 2 or 3. The most common is inferior rectus followed by medial rectus. Number 3, most often than not, the apparently normal eye also shows 1 or 2 muscles slightly enlarged. These muscles do not enhance on contrast, and these muscles, single lateral rectus muscle enlargement is never seen in thyroid orbitopathy. If lateral rectus is enlarged, as you see here, some other muscle must be enlarged, as you see the medial rectus here. And there is no contrast enhancement of muscle, lacrimal gland, or fat. Here, if you look, this is the myositis component involving the lateral rectus, which is contrast enhanced, and this involvement extends up to and onto the tendon. The tendon is also involved. Here, the lacrimal glands are enlarged. This is the lacrimal gland, which is in front, is the lacrimal gland, and this is also enhanced on contrast. Orbital fat may be enhanced on contrast, as you see in this case. Single lateral rectus muscle enlargement can occur in idiopathic orbital inflammatory syndrome, and it could be unilateral or bilateral, just like thyroid eye disease. Enlarged extraocular muscles occurs, as I said, thyroid-related arthropathy is the most important cause. And as you see here, this is the optic nerve surrounded on the four sides by the enlarged superior, medial, inferior, and lateral rectus muscles. This is in the mid-coronal plane. This appears good because there is a lot of space between the optic nerve, but when you come to the left eye, it's much less. As you go behind, so where the orbital space at the post apex is narrow, what happens? All these four muscles are compressing with too much enlarged, compress on the optic nerve and lead to compressive optic neuropathy. So, coronal sections in the posterior third are very important to know whether there is compressive optic neuropathy or not on CT scan. Here you see, this is the reflected tendon of the superior oblique. So this is the muscle belly of the superior oblique and this is the reflected tendon. When you compare it with the normal, it is hugely enlarged and you can see a cystic space with a scollens, hyperdense. So this is case of a myocystic involving the superior oblique. So usually one muscle is involved in about 2 to 3% of cases of orbital myocystic. There could be intracranial myocystic. That's called neurocystic. Can also be associated. These are all the myocystic components. The medial rectus. You can see the cyst and you can see the scolex. This is the enlarged medial rectus in case of myocystic. Enlarged extraocular muscles. If you look at these two in the coronal section, you can see that these extraocular muscles are enlarged, all the four, when compared to the other on the normal side. And if you look carefully, this hyperdense lesion that you are seeing is the engorged superior ophthalmic. When you see its size when compared to the other, on the normal side, it's very much enlarged. If you see this patient has proptosis with chemosis and the levo version is abduction is restricted on the left eye. Abduction is restricted. There's a pulsatile proptosis. Bruit is heard. Intraocular pressure is raised. This is a very typical case of carotid cavernous fistula. In carotid cavernous fistula, this lady, again, you can see there is a proptosis, engorged blood vessels at Clapper Murse. When the patient is looking to the right, this eyeball is not abducting, right eye is not abducting. Intraocular pressure is raised, venous engorgement is there with a pulsatile proptosis. What does the CT show? The CT shows engorged blood vessels with very grossly dilated superior ophthalmic. When compared with the opposite side, this is very grossly dilated. This is a very high flow fistula. High flow fistulas are commonly after trauma, and we see quite a good number of these cases because of increase in the road traffic accidents and not wearing a helmet. Other causes of extraocular muscle involvement is the enlarged extraocular muscle with the middle rectus is lymphoma. Here you can see the typical pinkish mass arising from the fornix. This is called the Salmon's patch. So here you can see that the mass is surrounding the globe without distorting its shape in all the three sections that we have seen. And there's a grossly enlarged medial rectus and it is extending all through as a pinkish mass. So this is a lymphoma. A biopsy will confirm the diagnosis and can be referred to an oncologist for further management. Similarly, case of lymphomas, bilateral with typical Salmon's patch from the fornix and along the limbus. This child again had a proptosis, and the CT shows a big mass with a little intracranial extension and surrounding the, without distorting the globe. And he underwent surgery. We have removed it as much as possible, then subjected to radiotherapy, and the child responded well. Enlarged muscle can also be in metastatic lesions. This lady came with the complaint of proptosis, pain, and discomfort in the left eye with motility restriction of abduction. She gives his of 1 month duration, gives history of underwent radical mastectomy for carcinoma of breast 1 year back, and the CT shows engorged lateral rectus muscle with bony erosion, which is typical of a metastatic lesion. So it just did a FNAC, no big procedure, and it showed the malignant cells, referred the patient to oncologist. This boy, about 18 years of age, came with proptosis right eye and motility restriction. And the CT scan again showed a mass in the superior and lateral regions with bony erosion, as you can see here. So, short duration of 1 month, motility restriction, proptosis, pain, bony erosions, irregular margins all point out towards a metastatic lesion. We did a FNAC, it's a neuroblastoma. So the patient was not aware of the, unlike the previous case, there's no history or previous diagnosis. So the metastasis into the orbit is the presenting symptom of the malignancy in this patient. Here you can see two patients of rhabdomyosarcoma with different presentations. Both had duration of 2 weeks only, whereas this patient, you can see a very huge mass in that's the superior rectus that is being enlarged with bony excavation and also erosions here, because it's a child, the bone has given away very early, and presentation typical of a orbital cellulitis. Whereas this is less dramatic in appearance and pain and all that. Here you can see an eccentric proptosis with fullness eyeball is pushed down, and the CT scan shows a mass lesion that is undergone the superior rectus with bone that is giving way and bony excavation. So we did biopsy, confirmed the diagnosis, referred to the oncologist, and they responded well. Here is a case of optic nerve glioma. When you see a mass in the intercoronal space in the coronal section, the first thing that you have to look at is it separate from the optic nerve, or is it arising from the optic nerve? Since the optic nerve could not be seen, that means it is a optic nerve tumor. The two most important tumors of the optic nerve are optic nerve glioma and nerve sheath, optic nerve sheath meningioma. How to differentiate? When the glioma is there, around the glioma you have the sheaths, meninges. So it's very well encapsulated with very clear-cut borders, uniform, a little hyperdense, uniformly present, isodense lesion throughout, no heterogeneity, there is no calcification, no contrast enhancement, right? This is a uniformly dense lesion without contrast enhancement, without calcification, and that clear-cut borders, that is optic nerve glioma. Now look at this. This is optic nerve sheath meningioma. This is irregular. It is arising from the meninges, that the outer close. So it is irregular, as you can see here, very, very irregular borders. And it is not uniformly dense. Some parts are hyperdense, some parts are isodense, and like that. And this calcification will be there on around the optic nerve, so that the optic nerve is seen as a hypointense lesion, and this is called typical tram track appearance. And the contrast enhancement will be there, calcification is there, tram track appearance is there, this hypodense area is the optic nerve glioma. The surface is irregular and not clear-cut borders, as you see in optic nerve glioma. This is how you differentiate optic nerve glioma from optic nerve meningioma, which can be easily identified on the CT scan. Optic nerve enlargement can also sometimes occur in idiopathic orbital inflammatory syndrome, where you can see that the nerve is enlarged, the borders are irregular, and also you can see the fat is also a bit infiltrated. It is not black as in the other eye. The medial ductus muscle is also enlarged and myositis component. This is a typical case of inflammatory orbital, idiopathic orbital inflammation with involving the optic nerve and usually responds very well to steroids. Here, if you look at this patient, you see intracorneal mass lesion, which is uniform dense, little hyperdense with the vitreous naturally, and isodense with the brain. The borders are clear cut. It is in the intracorneal space, and the same thing if you look at, this is the optic nerve. So this tumor is separate from the optic nerve. So it's the intracorneal mass lesion, and the most common intracorneal mass lesion with these typical presentations of long-standing lesion, usually a couple of years by the time the patient comes to us. Number two, uniform the isodense with the brain, margins are very clear-cut, and minimal contrast enhancement will be usually seen. That is typical of cavernous hemangioma. So if you look at this, again a case of similar mass, the same mass, with away from the optic nerve. This is the mass with clear-cut borders, and the cavernous hemangioma has been excised. This is the excised tumor. And here if you look at, there are dark spots in this hemangioma. You can see dark spots. It's not uniform. These are phleboliths and occur sometimes in long-standing cavernous hemangioma. This is a case of a neurofibroma. You're looking at this, we can make a clinical diagnosis with a typical lid signs, swelling, and the temporal fullness. And the CT shows a diffuse mass involving the lids and the temporal region with a heterodensity. Some are hypodense, some are hyperdense and lesions, and irregular borders skirting around the globe. This is typical of neurofibroma. And whereas in von Richtling-Hassen's syndrome that you see here, you can see multiple tumors. Again, you can see the neurofibroma involving the lid. And the CT shows multiple tumors. The more important thing is in these situations, there could be loss of orbital roof, bone on the orbital roof, so that the brain herniates and it can lead to a pulsatile proptosis. Lacrimal gland tumors, if you see, the most common is pleomorphic adenoma, which is a benign tumor, isodense with the brain, very clear marcations. There may be little excavation of the bone and no contrast enhancement. Whereas if you see it's adenoid cystic carcinoma, what happens is there is a bony erosion and the surface is irregular and infiltrating, and it need not be uniform dense. So this is how you differentiate adenoma from a lacrimal gland. Here is another case of adenoid cystic carcinoma of the lacrimal gland with bony erosion. This is also the same adenoid cystic carcinoma of the lacrimal gland with bony erosion. You see, it is cutting or molding around the eyeball without indenting it, because this is a soft tumor, just like a lymphoma. It cuts around the globe where it is in contact with, it doesn't flatten it. And you can see that the eyeball is pushed down and in by it, and the space between the orbital margin and the eyeball is very less when compared to the opposite side. Similarly, the upper part is much less, showing the displacement of the globe down and in. It's a case of nocturnal abscess. So you can see the abscess, the enlarged inferior rectus with the border and the irregular borders, and this is the tumor. This is the patient how she was looking. The foreign bodies were removed and she has recorded the health. This is the cysticercosis patient that I have shown you previously. A cysticercosis involving the myocysticercosis superior rectus LPS complex with assistant scolex. The scolex could be seen very clearly in the B scan. Patient was put on albendazole and prednisolone at albendazole at dose of 15 milligrams per kg body weight in 2 divided doses per day, and prednisolone at a dose of 2 milligrams per kg body weight, and tapered over a period of 4 weeks. She responded very well. Secondary proptosis. Here you can see a big basal cell carcinoma with extension into the orbit, as you can see here cutting around below. Extension into the orbit and with bony erosion, which needed exenteration. Contrast enhancement. Whenever we are looking, we ask for contrast whenever I am looking at a tumor or when I am looking at a vascular lesion. Right. Otherwise, there's no need for a contrast. For example, thyroid orbitopathy, there's no need to ask for a contrast. Similarly, in case of a fracture, there's no need to ask for a contrast. Right? Myocysticercosis that you are expecting, there's no need to ask for a contrast. If you are looking at a tumor, you want to know, because if there is a severe contrast enhancement, as you can see here, and similarly in this picture, when there is such a severe contrast enhancement, there could be a lot of bleeding during the surgery, and you may require to keep 1 or 2 units of blood before you start your surgery. 3D reconstruction is very useful, especially in fractures, so that gives us an idea what to do. Here is a 3D reconstruction of a patient with a congenital deformity of the frontal bone, and also you can see a hair lip. I'm sorry, what do you call that? Hair lip, right. I'll give half a minute time. I want whether people can read this CT and tell me what it is. Do we get the feedback? No, we don't get. Okay, here if you look at this, look at the bone. Here there is an excavation. Then here there is a lesion, cystic lesion, and there is a gap in the lateral wall, and this is extending into the temporal fossa. So this is a dumbbell dermoid. This is a case of dumbbell dermoid. This is the orbital portion. This is the defect in the bone, and this is the part of it in the temporal portion, and you can see that bone is excavated. Here you can see something like a second eye. This is the cyst with a bob, isodens with the vitreous, and there is a little bit of excavation. This type of cyst with cyst wall and the isodens with the vitreous is typical of hydatid cysts. What is this? Again, you can see that this is white membrane, thick membrane. This is the periosteum. So the subperiosteal space is filled with something. As I said, it could be either pus or it could be either blood. Subperiosteal abscess or subperiosteal hemorrhage. If you look at the sinuses are clean and normal. So it is a subperiosteal hemorrhage. If the sinuses are involved, as I have shown in the lecture, it would have been a subperiosteal abscess. This is a case of subperiosteal bleed. What do you see here? Here you can see that there is a proptosis on right side, this is right side. And if you draw a line connecting both the anterior-most part of the lateral wall in the mid-level, it should cut the globe 2/3 to 1/3. But here it is going below that. So there's a severe proptosis of the right eye. The medial rectus, if you look at the muscles are enlarged, and you can see that the superior ophthalmic vein is engorged when compared to the other side, which is thin like this. So it is a case of carotid cavernous fistula. Thank you for your attention.
Any questions, Shyam?
There are any questions is asking? No, sir. No questions, I
Okay, sir. Thank you, sir.
Okay.